Okay, Dr. Ola, you can start. Hello.
So diagnostic criteria for infective endocarditis based on the modified Dixie criteria. We have two major or one major plus three minor to get definitive endocarditis, and possible infective endocarditis if we have one major and one minor plus three minor criteria. Major criteria including blood culture positive for typical microorganism as Staph aureus, Enterococcus, viridans, Streptococcus, and also strepts, group B strep, group D, and also can be Pseudomonas infection. Echo with showing valvular vegetation. Minor criteria for predisposing cardiac lesion. IV drug user, this one for older patient. Temperature more than 38. Embolic phenomena. What's this embolic phenomena? Like what?
Maybe dactylitis or
Stroke.
splinter hemorrhage.
No, this rot spot and all. Rot spot and all, it is comes in embolic phenomena.
Embolic means because there is lodging of the embolus and going and settling in another place and causing the problem. Even this dactylitis will come under it, right?
I don't know, but this rot spot, this was the example of this phenomenon.
Okay. Go ahead, Dr. Ola.
Okay, and last one, immunological phenomena and positive blood culture not meeting above criteria. And so the easy way to remember these criteria, there is another way. Remember B tiger in the second slide. Can you share the second slide?
Okay.
So the for the major criteria, the positive blood culture, as mentioned, 3 blood culture from in three different sites 6 hours apart. Echo, which indicate valvular vegetation. Minor criteria, remember the tigers. T for increasing temperature. I for IV drug use. G for the immunological complex mediated glomerulonephritis and other immunological phenomena. E for embolic phenomena. R, read cardiac lesion which predispose infective endocarditis, and S, solitary positive blood culture without any above criteria. You can take screenshot for this slide. It is a nice slide.
No problem. I will share in the group.
Okay.
WhatsApp group. Now it is prayer time here. Anyone has comment about the case, please go ahead before we, and we will continue with video at 7 p.m.
So 25 minutes break, right?
Yeah, but still, if 5 minutes, if anyone wants to add anything, can go ahead. Dr. Ola, these 6 blood cultures you read from where? In the NICE guidelines? Sorry, these 3 blood cultures 6 hours apart.
From patient info.
Okay, because this, I think I read different in the, I will share 1 minute, 1 minute. I will.
Two blood culture 24 hours apart.
Before that, I will share one important slide for this is very because this can come even in the other stations as well. Patient at risk of infective endocarditis. Who are the patients at risk? Acquired valvular heart disease with stenosis and regurgitation. So rheumatic heart disease, for example, it is the commonest acquired valvular heart disease. Then hypertrophic cardiomyopathy, previous infective endocarditis, and structural congenital heart disease, including surgically corrected palliated structural conditions, but excluding isolated. Yeah, these are the things which are excluded in from the risk of infective endocarditis. Isolated ASD, fully repaired VSD, or fully repaired patent ductus arteriosus, closure devices judged to be endothelialized. Then valve replacement. So all these things are the risk for infective endocarditis. So provide patient advice.
So,
Provide why antibiotic prophylaxis is not routinely recommended. We have to tell that it is not routinely recommended now, and importance of good oral health is very important. Symptoms that may indicate infective endocarditis and when to seek expert advice. Risk of undergoing invasive procedures, including non-medical procedures like body piercing. They have to avoid this piercing of the ears, tattooing also, along with the good oral health. This has to be explained. Okay. They have to avoid the procedures which are non-medical, means this is not needed. This is just for the cosmetic or their appearance. They want to do body piercing and tattooing. So prophylaxis against infective endocarditis, when we are doing, this is very important. They can ask now, not recommended routinely for children undergoing dental procedure. And also it's not recommended now. And also don't use chlorhexidine mouthwash as prophylaxis. Then non-dental procedure at following sites: upper and lower GI tract, genitourinary tract, upper and lower respiratory tract, include ENT procedures and bronchoscopy. For all these, they are telling no need for the prophylaxis. Maybe still major surgeries you need it, right? For dental procedure, for upper and lower GI tract, genitourinary tract, and even ENT procedures, including bronchoscopy and upper and lower respiratory tract procedures, they are telling no need for the prophylaxis. Infection: to reduce risk, investigate and treat promptly any episode of infection in a child at risk of IE. So you have to investigate and treat promptly if you think that this child has risk of infective endocarditis. If at risk of infective endocarditis and receiving antibiotic for gastrointestinal genitourinary procedure at a site with suspected infection, give antibiotics that covers organisms that cause infective endocarditis. Yes, Dr. Ola.
So for our case, yes, I want from you all to just forget the regular amoxicillin. It is in our case, it is indicated. The antibiotic prophylaxis indicated in this case.
Okay, means routinely or for the procedure?
For the procedure.
But he is telling not for all procedures. He is telling not needed for dental procedure, not needed for this. For example, you're doing an endoscopy, upper and lower GI endoscopy, not needed. Or any like cystoscopy or anything, not needed. And bronchoscopy, like this procedures, not needed. Maybe if you do a major operation like laparotomy or something, you will need it. This is what I understand. Not for
You
all.
mean even for high risk? Even for high risk patients?
This is the new thing. Yes. They are not here. They are telling for dental procedure now it is not routinely recommended. Maybe high risk mana what like this, like our case.
A fat risk of infective endocarditis and receiving antibiotic for GI genitourinary procedure at site of suspected infection. Give antibiotic that cover organisms that cause infective endocarditis. Like in our patient, he's at high risk of infective endocarditis.
Okay. So when we do procedure, you are telling
So,
it is needed.
it needed for invasive procedure.
Yeah, invasive procedure, that's what I am telling.
Yes, for this patient, now he required treatment for infective endocarditis, but later on, with he became also major risk because he has a cyanotic congenital heart disease and also previous endocarditis, for example. So what is the future plan for him?
No, what
So they will give
if you
antibiotic
want
for
to,
dental procedure and
I am asking you a simple question now for all. Now this child is operated for TGA, both palliative and corrective surgery. Now he has a procedure like maybe endoscopy or something. Okay. Do we give the prophylactic antibiotics? This is the question. Endoscopy will put the, no, he is not in infection. Presently, he is normal, he is stable, and he has no signs of infection. You just want to do a gastrointestinal procedure, that is endoscopy. Do you think you will give the prophylactic antibiotic?
No.
No. According to this, what is written here? No. But suppose if the same child, if at risk of IE and receiving antibiotic for gastrointestinal genitourinary procedure at a site with suspected infection, means you are doing some procedure, maybe it's an abscess at a site of suspected infection. Suppose it is an abscess or something you are doing and you are opening it. I think you have to cover for infective endocarditis. That is what he's telling. This child is at risk of infective endocarditis. What?
Major surgery they do. But
major
not,
surgery, and if there is, you are doing some procedure and at the site of procedure there is infection. To prevent that infection, you'll give antibiotics. That's what he's telling. Receiving antibiotic for gastrointestinal and genitourinary procedure at a site with suspected infection. You are operating at a site where there is infection. At that time, you have to give the organisms to cover IgE. But normally, if the child is stable and has no thing for simple procedures like dental and also for bronchoscopy or endoscopy or cystoscopy, no need to give. This is what I understand from this. Okay. Okay. So I think we are getting late now. I will stop or end. We will start again at 7 p.m. For the blood cultures, I read it different. I will share you later. Huh?
Okay, just one point I want to clarify. That is what is the difference between the immunological phenomena and the embolic phenomena.
Okay.
Yeah. So for the immunological phenomena as splinter hemorrhage, rough spot, glomerulonephritis.
I told
And
splinter hemorrhage also. Yeah. I told splinter hemorrhage. Krishna told rod spot. What is the one more you said?
immunological phenomena, splinter hemorrhage, rough spot, glomerulonephritis.
Okay.
Rod spot is
For embolic or immunological?
No, it is immunologic.
Rod.
Then what is embolic? You have example for embolic?
Embolic like cerebrovascular accidents and
Capsulitis.
lung or splenic emboli.
Okay.
This is considered the embolic phenomenon.
Okay, so splinter hemorrhage, rod spot, and glomerulonephritis is immunologic. Embolic is CVA and splenic infarcts, and even I think
Lung.
even dactylitis you can consider in this.
Mm.
Okay, so we will meet after some time. Okay.
Okay.